we have a really busy morning. I just want to recap again to use that Q&A function at the bottom of your screen to ask questions. We are here again in our second morning session. We are thrilled to have our speakers, and I'm going to turn it over to Ben and Ritu.
Good morning, everyone. Welcome back. So it's my pleasure to introduce our first speaker of this second session, Dr. Ken Kilgore. Ken currently serves as the Chief Scientific Investment Officer for Beyond Celiac Disease. Beyond Celiac. He's an author of more than 60 scientific publications and completed his executive MBA at St. Joseph's University in Philadelphia. Over the past 20 years, Ken has held a series of positions in the pharmaceutical industry, including Pfizer, GlaxoSmithKline, and Janssen, where he was director in the immunology therapeutic area. He's also active in the venture capital and biotech startup communities in Pennsylvania and Michigan, where he is a member of the Life Sciences Innovation Hub at the University of Michigan. He will be talking on the topic of neuropsychological impact of celiac disease, a patient-scientist perspective. Dr. Kilgore.
Thank you, Ben. I appreciate that. Just going to share my screen, and we'll get started on things. So, slideshow. Is that good with everyone?
Yes.
Okay, great. So let's just, I guess, kick right into this. So first of all, thank you so much for the invitation. I certainly appreciate the opportunity to not only present a talk, but also to share my experiences. And in fact, I think that's one of the things that I'd like to do most of all is not really delve deep into the science of things, but maybe to provide a different perspective, and I term it as the patient scientist perspective. But I do want to go over a couple of major items here. One is, again, it's what I call the many faces of celiac disease. And what I mean by that, we'll go over that in more detail, is I think there's some interesting, well, I'm a history buff, first of all, and there's always some interesting things as you examine history and some good learnings that you can take away from doing so. So that the first part of it is really tracing the impact of celiac disease on my family in particular, thus the patient aspect of it, because it's certainly taken a toll on things. The other part of it, of the discussion that I'd like to have today too, is really representing how best Beyond Celiac, which again is a 501c3 nonprofit, located outside of Philly, but how we're engaging in research around these neuropsychological manifestations of celiac disease. And it's something that is of great importance to us and really has resulted in a lot of shifting of our strategy, especially within the last couple of years. So we'll talk about that. And then, if we have time at the end, sort of go into some ways that I think one of the things we need to do, there's a lot of great science coming out in these areas. I'm sure we'll hear more today, but also to start talking that discussion of how do we translate that science into effective treatments, whether it be for celiac or targeting the neuropsychological symptoms themselves. So here's the obligatory disclosure statement. Don't think we need to spend a lot of time on that. Pretty basic. So talk about the celiac family, or what the family tree, so to speak, and really what we've traced things back to, from my lineage is back to 1845 with some of the long gone relatives, so to speak. But what was really interesting about all of this is that we gained access to some diaries years ago. This is probably about 25, 30 years ago from my great-grandmother at the time, but she would spend an enormous amount of time talking about my great-grandfather who had stomach issues all the time, who had intestinal issues all the time, lost over, as we see here from these diaries, lost over 45 pounds and over time, and eventually passed away a few years later. I think the key here is that this was really the first indicator of what I feel is likely to be celiac disease in our family. We're direct descendants from Ireland, which obviously is a sort of the hot spot one of the hotspots for that. But certainly it was an interesting exercise in looking at the history and tracing this back on how it's impacted, back in the early 80s, or excuse me, the early 1930s, and even back further from that, how it's impacted the family. As we move forward, this is actually this photo that was taken probably in the late 90s or something like this, but I traced this out because it I think really has a lot of key messages to it. One is that celiac has really hit our family quite hard. And my father, who is right here in the middle, was really in 2003 diagnosed with the T-cell lymphoma associated with celiac disease and passed away a few months later. But that's really what triggered the family to undergo a lot of different testing for celiac. And what I have here circled as in green are those with the active disease, including my daughter. Again, my niece right here in the yellow tracing, she has had a child recently. Again, this picture is 20 something years old, just to give some context, but who has now, at least from a genetic standpoint, at risk for celiac disease, and also a nephew of mine who is in line for that. One of the dog is fine though, so that was good, not anymore. But the key thing here is that we have a lot of individuals with celiac, and the manifestations of the disease have really presented themselves in very different ways. And what's key for this talk is that what we as within the family itself are hit hardest with is not the GI symptoms. That's not what really triggers our family from a GI standpoint. That's not it. If we eat gluten, it's not that we're worried about the GI issues. It's really we're worried about the brain fog, the increase in depression or migraines and things like this. That's really what hits our family. It's not the GI. It's the neurocognitive issues, and it's something that is quite interesting from where I sit, in that how this phenotype is expressed, or the symptoms associated with this is so heavily geared towards the neuropsychological components as opposed to the GI components, to such a degree that when I was, let's see, probably 5-6 years ago, when my mother-in-law was visiting, she actually accidentally, maybe, gluten me, and I could seriously, the next 2 days, barely find my way home from work because the brain fog was so severe. It ended up just taking a few days. No GI symptoms, simply the brain fog really just shut me down completely. So I bring this background up is really, I think it brings some salient points, which is that in a lot of cases, at least I'll speak for the family, it's not the GI effects, it's the neuropsychological component that impacts us. And thus, from a diagnostic standpoint, we probably to this day would not be tested, except for my father developing that rare type of T-cell lymphoma back in 2003. So it's certainly something to be cognizant of, that these celiac disease is a tricky monster here, and does express itself in very different ways. That aren't, as I have here in the last bullet point, that are not classic in nature. So one of the things that I did is, again, we transitioned from more of the patient into the scientist perspective of things, is I left Janssen Pharmaceuticals in 2019 and joined Beyond Celiac as their Chief Scientific Investment Officer. One of the reasons that I did that was because I did have a passion that I wanted to go. I spent 20 years in autoimmune diseases, and I really wanted to go at celiac disease. So the opportunity presented itself, and it was a very opportune time because Beyond Celiac was shifting really away from an advocacy towards more of a science-based organization. So it was wonderful to be able to join that as that all was developing 2 years ago. I will say this, though, and I think this is a key indicator of people's interests, is that Beyond Celiac was interested in neurocognitive effects way back in 2010. Not much definition behind it, but certainly there was a lot of issues that were being noted from a neurocognitive standpoint. And it really did start to drive the future of the organization over the next decade. What we did a few years ago was establish a well-defined scientific strategy with its own group of scientists, including myself and a number of other individuals. One of the remits of that science team was to expand beyond just the GI manifestations. So we are obviously very interested in the GI, and that's by no means ignored, but certainly to branch out into these other less recognized areas of the disease, whether it be neurocognitive issues, thyroid function, diabetes, that sort of work. We have, and I'll talk about in a little bit more detail, we have increased the number and the size of our grants, and I think that that's something that's key to our success. It is from a scientific standpoint and the field itself. We did expand our scientific advisory board, was expanded to include psychologists, a number of other people that have experience in a broader autoimmune standpoint, things like this, just so we can bring a greater degree of experience and expertise to the table to really complement the GI-based individuals on that board. We also, over the last, just about a year ago, established a partnership with Janssen Pharmaceuticals. This is a split, I won't go into detail on this, but it's a split partnership where we each put in close to $500,000 into a partnership grant. And we will be announcing that, what we'll be looking at from a microbiome standpoint in a few months. But again, I use this as an example of really a different way of approaching our granting program and partnering with, in this case, Janssen or other big pharma, certainly possibilities for biotech, but to bring a different type of expertise to the table as well. The other point that we have here is that we are accelerating drug discovery efforts, and I'll touch upon that, but just briefly looking at increasing our clinical trial recruitment. Obviously, that's key, especially in the times of COVID. And also looking at developing funding mechanisms to enable early stage biotech companies. But what I want to focus in on for the rest of this conversation is really the things that we're involved in that pertain to more of the neurocognitive aspect of it. And this includes 4 different grants that we've put in place. I'll touch upon these briefly and go over each one of these. They're all in different stages. One is complete, the first one, and then the other 3 are either ongoing, about to be initiated, or still under that diligence phase, if you will. But again, going back from the historical perspective, we, as I mentioned, were interested in this in 2010 from the neurocognitive standpoint. I say we, meaning beyond celiac. The other real, I think, success of this has now come to fruition, and just recently where a paper was published in 2001 in the Journal of Clinical Gastroenterology, where we did a survey in collaboration with the group we were collaborating with. I forget the exact name, so forgive me, but we looked at different neurocognitive symptoms associated with acute gluten exposure, and then went through, looked at the patient feedback that we were getting, and what we saw was that both celiac disease and the non-celiac gluten sensitivity had profound impacts on whether it be concentration, mental confusion, forgetfulness, some of these other issues. And so I think that this data was really key to capturing the degree, the issue, the size of it that we were having to deal with from a neurocognitive standpoint in celiac disease. And you can see, again, just looking through this in brief, but that we really did show that this could be severe in patients with both of these conditions. So there definitely is that, that connection between the gut and the brain, and it is amplified in celiac disease. Now, one of the other points that I want to touch, and this is a grant that's ongoing with Paul Klennerman's group over in the University of Oxford, and was really was really funded to look at the role of T cells, and this is an ongoing group, or an ongoing grant. But I think it's interesting because some of this things that I'll talk about is only I can't go into detail, but it's only a few weeks old because we did get an interim report recently, and I do want to bring this out again without going into detail. But this group that was interested in Paul's group looking at really T cells really came upon another discovery that's quite interesting. They were looking at a lot of the different types of secreting cells or sensory cells in the small intestine, really focus on intraendocrine cells, tough cells, Paneth cells, and transit amplifying cells. They looked at this in 3 different groups, the changes. So they looked at the changes in celiac disease versus healthy individuals. And then looked at, and I think which is a very interesting component of this, they also looked at those that are on the celiac diet. So where the symptoms have been largely removed, they have celiac but are effectively treated on the diet. And that's the 3rd group. What is really, I think, outstanding with this work, and again, look forward to hearing more from Paul's group, but obviously, as I mentioned, when you compare it to healthy individuals, celiac, as you might expect, has major changes in these cell populations. What's surprising is the effect that the gluten-free diet has, and I think more importantly, does not have on altering these changes. So we do have a bit of a disconnect by what individuals may be looking at from a symptom standpoint. But what is going on within the intestine itself is quite interesting, in that some of these changes really don't reverse by any stretch of the imagination. So what occurs in many instances doesn't change back or revert back to a normal phenotype when you look at it from different cell populations. Finally, and I won't get into detail here just because Ian and Nigel will be talking in a moment, but we will be initiating a study quite soon, I hope, to looking at evidence-based, looking at imaging or MRI brain scans and looking for changes in individuals with celiac disease. And again, no need to go over a lot of detail here, as Ian and Nigel can certainly will take that on, but I do want to express my excitement about this, because I think what we have a key need for are these type of imaging studies, and where we can now start to relate, and we're trying to make these connections where we can really start to relate the changes in the cell population in the gut, as I just discussed, correlate those changes to what we see in a MRI, looking at brain scans, and really start to make connections on those changes. And so I look forward very much to hearing more from Ian and Nigel on this regard. One of the other part, as we just move on, one of the other things that I wanted to discuss too from our standpoint at Beyond Celiac is obviously the science behind celiac disease. And I have here just from just a real quick simple search, looking at the number of publications over the last from 2006 to 21. I think back to 2003 when I was diagnosed, where there was next to nothing on it, but we've obviously evolved scientifically over the last almost 2 decades at this point, and that's a wonderful thing. The science has advanced, the opportunities to target celiac disease, as I have here, have expanded tremendously as well, and I think it's a really opportune time to be looking at treatments for and cures for celiac disease. And what I have here is, again, 2006, really, I use these as just a few examples, but that's certainly ways to target celiac disease, and the treatments have expanded tremendously as the science itself has matured, and as well as the therapeutic approaches that we can now bring forth to bear on this issue has matured as well. But one of the things that I think is quite important for this is really that we have to be able to translate this science into effective treatments. And I'm really, as I mentioned, very excited about where we sit right now in terms of treating this disease. And I think that we look at finally, and due to conferences like this, and so again, my much appreciation from the patient perspective is that we're recognizing these neurocognitive effects. We have that, as I mentioned before, we're exploring the brain and the function morphology in detail. And what's really interesting as well, and I think this is just a symptom of the slide that I just presented, which is the science has really caught up with the opportunity. And what we're seeing from big pharma, what we're seeing from the biotech sectors are so dramatically, the interest has increased dramatically. And the number of big pharmas interested in celiac has skyrocketed over the last 3 years. Certainly the number of biotechs that have expressed an interest in celiac is increased. So this is, in fact, I believe, riding the wave now for these sectors to really make an impact on a treatment. We're learning about the gluten-free diet, what it does and what it does not do. I speak for myself on this, but I've long suspected that even though my family is totally gluten-free, as my daughter has it as well, but totally gluten-free, I still feel the effects of celiac disease on a cognition standpoint, and that doesn't go away. And again, I don't get contaminated very often. It's been years since that's happened. So, but I do feel that there are effects that linger on even on the diet. And I think another part that I'll bring up too, and it's, I guess, just to maybe put a positive on why we're all sitting in front of screens today, but we are learning from different diseases on brain fog and the other cognitive effects of celiac. I think really a key here is to be able to recognize that other diseases, we can learn from those and vice versa, and that celiac can be considered a gateway disease. From the autoimmune standpoint, as many I'm sure know, that it's the only autoimmune disease with a recognized antigen, and therefore I think that this is the gateway to not only curing celiac, but celiac helping out with other diseases such as T1D and food allergies themselves. And then also from the COVID standpoint, brain fog is really hit the papers now, if you will. That's, I guess, old fashioned, but has really been brought to the front because of this COVID associated brain fog. And so I think it's certainly stirring up interest from the broader community itself. Really, what we're trying to do at Beyond Celiac to accelerate our discovery or the identification of new therapies, as we do have Go Beyond Celiac, which is the name for our online patient-reported registry. This now ties into being a key tool to recruit for clinical studies. We have a number of different partnerships, as I've mentioned, with pharma and numerous biotechs. And also we are implementing mechanisms by which to help the startup sector. And key to that is really to tie in the, say, venture philanthropy or our grants with life science venture capital, bring those together and to really accelerate treatment. So to really, if you will, invest financially into startup companies. I think from just the time standpoint, leave, I think this is the last slide anyway, yeah. But I do, again, in the last minute that we have here or whatnot, is to really express my appreciation for the opportunity to, I guess, provide a very high level view of at least our efforts at Beyond Celiac to address these. I would say that while I bring up Beyond Celiac, everything we do is partnered with other groups, with other individuals, many that are on the line today. And I want to thank them for just being open to these type of partnerships, because without the people on the line today, we certainly could not move forward. Again, open to questions, or certainly look forward to talking at the panel later on today. So thank you so much.
Thank you very much, Ken. Thank you for sharing your story and what Beyond Celiac is doing for the community and bringing the at least bringing forward information and interest in the neurological manifestations. We'll have you join us at the end of this session for quick Q&A, and we'll continue on.
Thank you.
Thank you. So at this time, it is really my pleasure and honor to welcome two speakers whose research has been really quoted by almost everyone this whole morning. Really, honestly, my honor and pleasure to introduce Dr. Hoggard and Dr. Crowell. Dr. Hoggard is the professor of neuroradiology at the University of Sheffield in the United Kingdom. And of course, we're really sorry with the time difference that you have to be talking to us at this time. Dr. Hoggard is at the University of Sheffield in the Department of Infection, Immunity, and Cardiovascular Health and its diseases. And of course, not a gastroenterologist. All gastroenterologists have been sort of dabbling in neuroradiology so far, so we'll hear it from the expert. Dr. Hoggard is a practicing consultant neuroradiologist. He has been in the space of gluten-related neurological disease and published extensively. He's also the founder member of the Sheffield Institution of Gluten-Related Disorders, starting in 2013. And the current research interests in the gluten-related diseases focuses on implementation for long-term brain health for people with immunological reactivity to gluten. And I'll continue the introduction with Dr. Crowell since they'll be doing this talk together. He is a research fellow at the University of Sheffield with a background in cognitive neuroscience, investigating both how a condition may affect the brain physically, as well as how in turn it affects a patient's cognition and quality of life. He joined the Sheffield group in 2017, has been involved in a number of investigations, and today we will hear from Dr. Hoggard. His discussion will focus on clinical perspectives of the neurological problems relating to gluten, and Dr. Crowell will discuss the current research from the University of Sheffield. And I know that all of us are really, really excited and waiting to hear from you. So I don't know who is going to start first, but I guess I see Dr. Hoggard, so please take it away. Thank you.
Thank you. Thank you so much for inviting us to talk at your meeting today. I'm going to sort of try and set the scene for the background to what Ian's going to talk about in his talk. And I want to take you back to, I seem to be getting control. Okay, right, fine. So I think one of the things we need to do is just clear up about the terminology. So we're talking about celiac disease, but also we're talking about gluten-related, a whole range of gluten-related disorders. And one of the things is we've tried to do is try to get over this idea that you don't need to necessarily have enteropathy, the gut-related symptoms, to have the neurological symptoms. And that's something obviously that we've just heard Ken talk about in detail. And it's something that we've been banging away on basically for a couple of decades really. So let's start off where we all kind of agree. So we're all fairly clear about what celiac disease kind of represents. You know, it's a fairly common disease. It's 1% of the population in the UK. And its classical symptoms are weight loss, abdominal pain, bloating, diarrhea, and, you know, anemia, osteoporosis, malabsorption, all those things. And it's based on basically histology from a biopsy of the small bowel, where you get these characteristic changes of inflammation, which are characterized by the Marsh criteria. So we're all clear on what celiac disease is, I think. But what I'd like to go back to is the original paper by a very, very close colleague of mine, Maros Hadjivassiliou. And he was a young man at this stage, and they had a whole cohort of patients with disparate kind of neurological conditions, which didn't really seem to fit in any specific group. But when they tested them for anti-gliadin antibodies, what they found was that there's a very large proportion of these people turned out to have an immunological reaction to gluten. And that was overwhelmingly more common in this group than in what we take as the population levels of healthy volunteers who give blood in the UK through the blood donor service. And that was 12% in that particular population. And so we have this evidence, therefore, that there are a lot of people out there with neurological dysfunctions of various varieties that are overrepresentative levels of anti-gliadin antibodies. And the frequency in the group with neurology with celiac disease was also quite high, 16%. So that means then, if we just look at those figures and just look at it, drill down a bit more, it means 40% of those with the neurology patients were positive for the anti-gliadin antibodies, but didn't have celiac disease. And yet their neurological problems improved on a gluten-free diet. And that's the critical thing. There's lots of overlap with other conditions in neurology, but it's that responsiveness to a gluten-free diet that is characteristic of what we're talking about today. And we were the first group who described this idea of changes in the celiac disease with neurology without celiac disease. Okay, right. So these are figures going back to 2019, and at that stage we had just over 1,100 patients with us who'd had gluten-related neurology. And I can say that we seem to have passed some sort of barrier, because that number is now well over 1,500 in the last couple of years. So I think there is a rapidly growing acceptance, I think, out there now that this is something that needs attention, and people are presenting themselves. We have people from across the UK coming to us as a centre to seek our care. And if you look at the breakdown of those patients, the majority of our patients have ataxia. One has to say there might be a referral bias there, because we are an ataxia centre, one of only 2 in the UK. So there may be a bias there, but clearly there's also a big proportion with peripheral neuropathy and something which we've termed encephalopathy, which might seem familiar to some of you with some of the neurological symptoms of gluten sensitivity. And we're just going to talk about that in a bit more detail, but you can see there's a whole raft of less common manifestations there too. Okay, so right, what do we mean by gluten ataxia? Well, these are typical kind of cerebellar kind of presentations. If you look at the histology, and we've done that in patients with gluten ataxia, there's a Purkinje cell loss. These are the classic iconic cells within the cerebellum, which are integral to the actual function of the cerebellum. And this manifests as clumsiness, loss of coordination in the arms and the legs, and a problem with walking and stability, standing and sitting, and sometimes with slurring speech. And the thing to say about this is, if it's left untreated, it's a serious condition. These people, if it's untreated, end up in a wheelchair. So this is not a trivial disease. And this is one of our early pictures of one of these patients. And these two sets of images, you can see one is from January 1998, and the second is from May 1999. And I hope you can see my cursor there, but this is the cerebellum. It looks bright because there's some inflammation within the cortex, because it's not normal cortex, the cerebellum. And then you can see what it looks like just 18 months later. And there's a significant change in the volume of the cerebellum there. And that's over a relatively rapid period. So this is a relatively aggressive end of the spectrum of this condition, but it is, as compared to most ataxias, towards the more aggressive end. Gluten encephalopathy. So this is something which I think Ken's really kind of described already. So episodic intractable headaches, which we've said mimic migraine. In my personal experience, I think it's a potential trigger for migraine. But what's important is that these headaches should improve. In fact, for about a quarter of people, maybe just go away completely on a gluten-free diet. Now, the foggy brain, can have significant cognitive deficits, and some people quite rightly describe like a lifting of a veil once they're actually on the gluten-free diet. And then we finally got this idea of white matter change. So this is the wiring of the brain that connects the different gray matter areas where all the neurons are. There's all these white matter nerve fibers, and they tend to accumulate what we call T2 signal chains. There are changes on the brain scan which accumulate, and that can be a part of normal aging, but we can see it quite rapidly accelerated in some people. And then we've got the other group, gluten neuropathy, and this is a disease that affects the peripheral nervous system, so the nerves going down to your hands and feet, because it tends to affect, it depends on the length of the nerves, how badly they're affected. So the longer the nerve, the more likely it is to be affected. And it also seems to be targeting the large fiber, so the things that tells your cerebellum where your joints are or where your muscle tension is, those sort of bits of information which are required for accurate movement and standing and all the rest of it in terms of coordination. But also there's a component of pain, and that tends to be small fiber involvement. So although it's predominantly large fiber, there is some small fiber involvement in some people. And that can all be demonstrated when you do neurophysiology tests on these people. And then just to the side, there's another condition called POTS, which is a postural hypertension syndrome. And that we think is due to vagal nerve neuropathy. And we've reported that in about 20 patients. Okay, so I'm an imager, so why am I interested in it? Well, I'm interested in it because I'm interested in trying to find useful biomarkers as a clinician. And this is where we started. So we did structural imaging, where we look at the size of cerebellum, and if you do three-dimensional imaging, then therefore you can work out volumes of these things, and you can target particular areas of the brain which seem to be involved. But there are also other changes, like I said. These are the white matter T2 signal changes. These bright areas are the abnormalities, which you can see in the cerebral white matter there of both hemispheres there. And we can again do volumetric imaging to work out volumes of this tissue change over time, and that can be measured. And then the other biomarker which we've used a lot is something called MR spectroscopy. This is like looking at the biochemistry of the brain, and this is something that you can do within an MR scanner. It's something that dates back from the 1950s with organic chemistry, in fact, but you can certainly see a number of chemicals in the brain. This is something called NAA, and that is a product of happy, healthy neurons. So if a neuron is damaged or dead, it drops as a chemical in the brain tissue. And this is something called creatine, and that's to do with energy metabolism in the brain. That tends to remain pretty stable no matter what happens to the brain. And we've used this extensively in our group, and this is sort of data it gives. So you get a spectrum here, and this is what we talk about. We talk about spectrum, you get this baseline here, and these are different chemicals. This is to do with the cell walls. This is the creatine, and that's the NAA, this healthy, happy neuron marker. And we've used that for monitoring. So when we're monitoring the people who are on the gluten-free diet, we do it with looking at the anti-gliadin antibodies. And this is a problem because in most centers that's stopped being available because it's not as specific as some other tests for celiac disease. But celiac disease is a disease of antibodies to TG2. And what we're looking at is a different manifestation of gluten sensitivity. It's got a different spectrum of immunology. And so it's not specific to gluten-related neurological disease. So we still use anti-gliadin antibodies. And when you look at different people, different groups, there are some people who say, I'm not going on a gluten-free diet no matter what you say. And we see that their NAA levels, that happy, healthy neuron levels that we find these people drop. And it's kind of interesting, isn't it? They're the people who are probably the least affected when we first see them, and they drop. If you, the people best motivated to follow the gluten-free diet tend to be those that are more severely affected, as you might expect. And they're the ones that see the significant improvement in NAA. And then we've got people in the middle who kind of stick to the diet, and they kind of are stable, roughly speaking, though there is a slight decline over time. And that's one of the reasons why we use this as one of our biomarkers. So I'm just going to leave you with this slide because I think it's quite telling, really. So we saw that quite rapid change in the size of the cerebella in that patient from the 1990s early on. This is another patient who, this is 2-year interval, okay? So these are the signal changes in the white matter of the brain that we're talking about with the encephalopathy. But here we are, it's become much more extensive, much more confluent, and that's very rapid change. That is not normal aging. That's much too rapid. And this is in patients who are also at the young end of the spectrum to be getting that severity of white matter disease. So I guess that's time to cue Ian, who's going to be looking at that in much more detail.
Okay, thanks, Nigel. And yeah, thank you very much as well to the University of Chicago for having us here today. Nigel, as I think everyone will gather a sense there, is a clinician as well as a scientist. I should explain that I'm purely kind of academic in my background. Before I joined Sheffield and have been interested in all of this, my research interests were dementia and brain injury and things like this. I'm going to be talking a bit then about the research that we've done. I'm going to cover a couple of experiments we've done quite recently, and then I'm also going to talk briefly about this partnership we've just started with Beyond Celiac that Ken has already introduced. And I'm going to talk a little bit on the other side of the coin that Nigel's been discussing, because of course we see a lot of these patients who have quite a severe neurological presentation, but who do not necessarily have celiac disease underneath that as well, even though it's still related to a gluten sensitivity. I'm going to be looking at, in this talk, at patients who do have celiac disease and kind of asking the question, well, to what extent can we expect them to see a neurological impact? Nigel, of course, covered that, we started to really medically integrate this into our ethos in the late 90s. But it's interesting that if you look in really kind of historical literature, you can find references back to neurological problems relating to gluten as long ago as the early 1900s. And even reading this now with phrases such as peripheral neuritis and ataxia, it's clear how similar this phenotype is that we've been seeing for a very long time now, for over 100 years. More contemporary research, if you want to look after the year 2000, has discovered, that celiac disease can be associated with ataxia symptoms, headache, sensory loss, as we've discussed. Nigel's already introduced you to white matter lesions, and studies also found some regional brain atrophy. Some epidemiological research reported an overall increased risk of vascular type dementia, which is a dementia subtype. There's a study that's reported reduced cerebral blood flow, and a couple of studies have also looked at cognition as well, reporting impairment compared to controls, and another paper which showed signs that cognition may improve to a degree once a gluten-free diet is started. However, I'm sure for any patients here or people with experience of this, it remains a bit of a contentious topic within literature. And I think there's been a certain sort of resistance to fully adopt this and integrate this into the clinical landscape. And this is an area of the research I'm really interested in myself. I think this resistance can be summarized by, for example, this publication, which was a couple of years ago now. It was a systematic review which looked at other reports investigating celiac disease, which themselves were reporting the prevalence of neuropathy or of ataxia in those cohorts. And you can see that even though clearly some of these papers did report, some prevalence rates, because we have up to 39% and up to 6% for neuropathy and ataxia, both of these also start at 0%, so these are reports out there saying we looked at our celiac disease patients and we found no evidence of this existing. So the argument can kind of go two ways here. The critique given against research which does produce significant findings is essentially that there's forms of biases operating within that. The patients being investigated may not be representative of celiac disease in general. Perhaps they're very specialist centres, so they don't see, typical celiac disease patients, or perhaps the data collection methods used are really quite specialist and not representative of what clinicians are generally interested in. Alternatively, it could be the reports which kind of insist there's no evidence are using ineffective testing methods. These are relatively specialized things we need to look at, and particularly brain injury is on a spectrum, and if somebody has full-blown ataxia symptoms, that's quite a blunt, fairly kind of obvious thing to observe, if you will. But there's a whole spectrum of things before then, which are maybe not as obvious to spot in a clinic, but absolutely still affect a patient's quality of life and their well-being. And we need more kind of sensitive tools to measure and investigate that, which I think is where a lot of this literature has been lacking. And this was summarized by this systematic review, where the authors wound up concluding that there's a danger to patients here because these people need to go on the gluten-free diet as soon as possible. It certainly seems to help the neurological symptoms and progression of that, which I'll talk about a little bit more. But these so-called controversies that we see within the field are kind of stopping the right serological testing from happening and the right diagnoses from happening in a timely enough fashion. So this brings me to the first of two experiments I'm going to discuss. This was published last year. And it was essentially a validation study which we did, which was trying to settle this debate somewhat. In this, we used data from a giant health resource in the UK called the UK Biobank, which people may or may not have heard of in this audience. I'm honestly not too sure. But essentially, this is an initiative which I think was led by the University of Oxford, and it started in the mid-noughties. And back then, they recruited 500,000 people from the UK. These were all essentially UK adults, approximately in middle age, but that was the only inclusion criteria. So they are of every healthcare background you can imagine, completely healthy people to people with all sorts of diseases and diagnoses. And then more recently, they keep updating this data. And one of the major updates they've given is that they are doing MRI scanning of the brain and elsewhere on 100,000 of these participants. The point being that this is independently collected data, from our centre. We have nothing to do with the UK Biobank, and certainly it wasn't an initiative started with the intention of investigating neurological impact of celiac disease. So there's no positive ascertainment bias going on in the data collection here. And also because this is a population study in the truest term, we know that these diagnoses will be representative of typical celiac disease. So we got access to this data. And we essentially looked to run a series of comparisons between celiac disease cases and matched controls within it. We were interested specifically in those patients where brain imaging data was also available. At the point in time when we ran this experiment, that was true of, I just need to move part of my screen here to see the numbers on the side, of 104 celiac disease cases who also were otherwise completely healthy. That was a point we were very pedantic on. No neurological history. We were excluding people down to if they had psoriasis as a skin condition because it's technically inflammatory and these sorts of things. And we also excluded anyone who was taking psychoactive medication at the time of data collection, so antidepressants and things like that. We then looked to find two controls for every one celiac disease participant, which we managed in almost all cases. And we matched them on a number of different criteria: age, sex, body mass index, level of education, and to control for vascular risk factors if they had a diagnosis of hypertension or not. And otherwise, controls were subject to the exact same study criteria. And as I say, we ran a series of case control comparisons. We looked at key scores from 5 different cognitive tests, and we also looked at responses given to 6 different multiple choice questions, which explored these participants' mental health in different ways. And we ran a couple of brain imaging analyses, which I'll get into a bit more in a couple of slides. But this revolved around a method which is called, a bit of a mouthful, it's called tract-based spatial statistics, or TBSS. And it uses a specialist kind of MRI scan called diffusion tensor imaging, which hasn't really been introduced into any clinical practice, but is very popular within research. So just to cover a bit of bookkeeping, I suppose, for the analyses, both groups were very well matched, is what the point of this slide is. The mean age was kind of early 60s for the participants, about 2/3 female. Everyone was well matched on the things that we matched them on, unsurprisingly. And we also checked smoking frequency and alcohol intake, which we were interested in as well. And we found that there were also no significant differences between the groups in those respects. We found when we looked at the outcomes for these participants that the patients with celiac disease did have a slower reaction time on that particular cognitive test, significantly so compared to the controls, and also that the celiac patients were significantly more likely to give answers to these questions that explored mood which could indicate a problem. So the specific questions this was true for were about anxiety, one about depression, if they'd contemplated self-harm at any point, and perhaps not quite so surprisingly, how happy they were with the state of their own health. So onto this brain imaging analysis, which we did. This was something which uses a type of MRI scan called diffusion tensor imaging. As this slide explains, this is very popular within neuroimaging research. What we're looking at on the left there is a way of analysing and constructing a DTI scan. This is a brain from one of the Biobank celiac disease patients. It's the first time this scan has ever been used in the context of study celiac disease. The reason it's a very popular thing to do is because it's very sensitive at analysing the brain's white matter, which we know there's indications are affected in celiac disease. So what we're looking at here on the left are all the white matter fibres of this particular celiac disease patient's brain. And when I say it's very sensitive at doing this, what I mean is it picks up changes in the brain due to pathology in a very, very quick and kind of timely early fashion. So as one example to describe this, it's known elsewhere in research to show changes which will later go on to become white matter lesions, which you will see on a more conventional FLAIR scan, but DTI will kind of pick that up sometimes years before the white matter lesion appears. And in these patients, sure enough, the DTI measurements were significantly different in patients compared to controls. And these happened in white matter tract locations, which are kind of symbolized here by the orange and red blobs over the green healthy tracts. These orange and red blobs are the areas that were different. And these kind of focused on the brainstem leading up to from the cerebellum into the thalamus and including the thalamus, and also some aspect of the corpus callosum as well. So that kind of leads me a bit into the second study, which we published just a few months ago. This was a follow-up study on an earlier, I will call baseline paper, which was published a number of years ago now, where initially 100 patients had been recruited immediately after being diagnosed with celiac disease from the gastroenterology department with no previous neurological history. So this was kind of another attempt to really capture, quote unquote, typical celiac disease and study that. And in that baseline paper, which isn't what I'm discussing here, it was kind of shown that neurological symptoms were fairly common amongst these patients, but there's quite a lot of overlap with what Nigel's discussed there. In this follow-up study, we re-recruited 30 of these people, and this was about 7 years after the initial assessment, and they all underwent the same measurements. They kind of re-underwent a neurological examination, tested their blood serology for gluten-related antibodies, and they underwent structural MRI scans. That's both at baseline and at this follow-up point as well. We found at follow-up that exactly half of the cohort, 15 of them, had achieved negativity of all gluten-related antibodies. The remaining half were positive clinically for at least one of these, but needless to say, the overall kind of titer of these antibodies had still dropped significantly across the board pretty much. When we look at how symptoms seem to have progressed over time, it's a bit of a mixed bag. And I should say immediately, for the scientifically minded among the audience, these do not represent statistically significant results. This is what you would call a descriptive sort of comparison of baseline and follow-up. But anything with a green arrow appears to have got better. So headaches, and one patient had nystagmus, which is a bit of an eye twitch sort of disorder, no longer had nystagmus at follow-up. But then a couple of things were completely the same and sort of flatlined over time. And a few of the patients appear to have got worse in some respects. So balance problems or ataxia are happening at a more frequent rate. And also loss of sensation in feet was something new. I should say that with this being a small sample size, it's difficult to tease out, the things that are driving this, but it did appear that serological positivity was a bit of a marker for this. So for example, of all the new people who for the first time were saying, I now have balance problems, I think there were 7 such patients, all 7 of those were still positive for some gluten-related marker. I then took this data and used that idea of, the serological positivity being a sign of something to investigate how brain atrophy might have progressed over these 7 years. So I focused on the cerebellum and the thalamus in this, because they'd both shown signs of being relevant in the baseline data. The thalamus did not show any significant results in this follow-up study, but the cerebellum did. In the cerebellum, we can basically observe that the rate of atrophy year to year was significantly different between those patients who had achieved negativity of their gluten-related antibodies compared to those who hadn't. It was over double, minus 0.73% versus minus 0.32% in those who still had antibodies. So I think that was actually a really exciting finding. I think it was actually the first that I'm aware of kind of direct scientific evidence this was statistically significant of essentially a treatment effect on the brain and how, you know, brain pathology is progressing relevant to this. So just to bring all of this together, you know, I've talked first about this validation study, which I think has hopefully now proved with real confidence that typical celiac disease does involve cognitive deficit, indications of mood problems, and some white matter changes on brain imaging. I suppose the hope there is that it continues to be, you know, more accepted within the medical community the more that research like that is published. There's a lot of indications of cerebellum and thalamus being relevant, and also that these neurological symptoms appear to occur in these otherwise typical celiac disease patients at a high rate. And finally, this kind of treatment effect underlying the importance of immunological negativity and therefore following strict diets. I will just very quickly in a few seconds, final slide here. As I mentioned, and as Ken mentioned, we've just partnered with Beyond Celiac. We want to look at this with much bigger patient data. 30 is not nearly a big enough sample size to really be confident about this, but we've got over 1,000 patients who've been coming to this clinic that Nigel's mentioned. So we've just started this very exciting project where we're going to thoroughly interrogate this data, the serology, the brain imaging, really look at patterns over time and what affects prognosis. So thank you very much all for listening. Thank you also to our partners and to our senior collaborators back at Sheffield as well. Thank you.
Thank you, Ian. Thank you, Nigel, for a really fantastic joint presentation. I look forward to the panel discussion at the end of this section. But for now, I'm delighted to introduce our last speaker of the session, Dr. Knut London. Dr. London is a professor and medical doctor trained in internal medicine and gastroenterology, and with a clinical practice focused on celiac disease and other inflammatory diseases of the intestine. He has for decades worked with the immunobiology on celiac disease in close collaboration with Professor Ludvig Solid, University of Oslo. Together, they've been very involved in many discoveries of the disease pathogenesis, including the genetic basis of celiac disease, the demonstration of pathogenic T lymphocytes in the intestines of people with celiac disease, and the critical role of the enzyme transglutaminase 2. And I should mention, Dr. London was a recent author of a New England Journal of Medicine clinical trial of a transglutaminase 2 inhibitor, a phase 2 study. His more recent focus has been on trials such as that, both investigator-initiated and industry-initiated. He's also instrumental in the establishment of the International Society for the Study of Celiac Disease and the European Society for the Study of Celiac Disease, where he serves as president. I've had the delight to work with him in this capacity as he's worked with the Society for the Study of Celiac Disease. Today, Dr. London will be speaking on the topic of, can we explain gluten-induced symptoms in celiac disease?
Thank you, Ben. May I share? Yeah, I guess you can screen. Now you see my screen now? Yeah.
Yes.
Very good. So thank you, and thank you for inviting me to not come to Chicago, but to talk to Chicago and magnificent audience. Not traveling allows me to do exactly what you can see on the right here, which is my favorite occupation during the autumn time. The things that we're going to touch upon is something about immunology and pathophysiology. A major discovery, as I see it, in 2019 publication. Then some clinical effects of gluten, rapid clinical response, the threshold of gluten exposure. What about gluten-free celiacs and non-celiacs? The effects of gluten on psychiatry, psychology, and cognitive function are among the topics that I'm going to address. As Ben alluded to, I'm serve as a president of the European Society for Study of Celiac Disease. We published a couple of years ago our guidelines, and I can tell you then that these guidelines have been really caught up by many people. 70,000 downloads. It's freely available. Everybody can go and download them, and also the app, which is I think is very much used. So it's a lot of interest in celiac disease, and which is really good for clinicians, but even more so for the patients, of course. What about this discovery in 2019? I know this is a crowded slide, and please forgive me. Maybe I've added too much details into some of my slides, but before 2019, the idea was that the T-cell response was just too slow to explain symptoms and disease pathogenesis in celiac disease. Rather, one focused on rapid effects on innate immune cell activation and direct effects of epithelial cells. And then in 2019, a really seminal paper came out by Bob Anderson and his colleagues. Banner Chabris is one of them. Oops, sorry about that. I was happy to be part of this as well. And this paper showed that if you expose people with celiac disease to gluten, they respond very fast, within hours, with a T-cell response. That was completely new. And it doesn't matter if you do it by injection. This is the injection route. So you inject the gluten peptides, they react with symptoms, or you give them per oral. Both types of challenges gives a fast IL-2 response, and I know that Dan Leffler addressed this in the first session today. And this is very important because we're going to come back to this also in distinguishing celiac disease and non-celiac gluten sensitivity. So what have we been working with? Well, we have been looking a lot about the activation of immune cells and symptoms during gluten challenge. We are very happy to have a lot of celiacs that volunteer for our studies. But I should say most of the celiacs that volunteer for challenge studies, they are typically not extremely responsive. So those who experience very pronounced symptoms, they would typically not come to our studies. We can understand that. So on the left here is symptoms during a 2-week gluten challenge measured by celiac symptom index, and you can say it goes up, which is fine. At that time, we also measured interleukin-2, the cytokine that I described in the previous slide, by yesterday's methods. Well, this actually is the other symptoms. But on the right side, we refined this and we looked for immune activation and cytokine secretion into the serum. And what you can see on this slide, I hope you see my cursor here, is that all celiacs that we give gluten to per oral, they respond with immune activation. I will not go into all the details here. These are activated specific gluten-specific T cells, and all respond. Some respond by several orders of magnitude, some not that much, and all respond more or less with IL-2. So we have very robust methods looking at detailed specific activation. This interleukin-2 is really interesting. As I said, it's a T-cell response. It's a immune cell response, which is really fast. So it comes up in just some few hours. And what our colleagues at the Immusanté and in Australia, Jason Tydin is working in Melbourne. What they observed was that those celiacs after a single oral gluten challenge, that those who vomit have high levels of interleukin-2. those who do not vomit have lower levels of interleukin-2. So it directly correlates with symptoms in celiac disease after gluten challenge. And this has been even more studied with this elegant and very comprehensive US study by Dan Leffler, Leonard, Sylvester. Oh, there's so many people here who have been involved in this really important study. Where you're looking at different amounts of gluten, and you can see down on the right here, celiacs, they react to 3 grams of gluten and they react to 10 grams of gluten, and the more you give them, the more they react. Again, this is the celiac disease severity score, so it gives you some description of the severity of the symptoms. But again, those who are really sensitive, they will not be allowed to enter these kind of studies. We recently, as Ben Level alluded to, we recently published this summer a paper in New England Journal. I'm very happy to cooperate with, oops, sorry about that, with Dr. Schupan and Dr. Meki and a lot of good colleagues. And what we did here was to investigate the effect of an inhibitor to an enzyme. What does this enzyme do? Well, this enzyme transglutaminase 2 is the target of the antibodies in celiac disease, and it also is directly involved in deamidation of a chemical modification of gluten during digestion. So this enzyme is really important for the pathogenesis. What happens if you block this enzyme? Can it be used for a treatment? And yes, we think it can. Look at the placebo response here. If you give celiac patients a good amount of gluten per day during 6 weeks, their villi will flatten. So this is the placebo response. The villi will go down from high, tall to lower, a typical response. Not all respond, but many patients respond compared to the 100 milligram and the 50 and the 10 milligram. So it's a dose-dependent attenuation of the response during a gluten challenge. But we were, I was asked to talk about symptoms. Does it affect symptoms? Well, then again, same paper, look at the celiac symptom index from baseline here to after gluten challenge. And this is a crowded slide, I know, but then again, look at these numbers over here. The response in the placebo group, the severity of the clinical symptoms go up during these weeks, whereas in the 100 milligram, the 50 milligram and the 10 milligram, there is not that much of a response. Although we did observe patients who had a lot of discomfort during this study, but still had acceptable, we couldn't find any mucosal changes. So some patients may in fact experience symptoms also with this drug. So this drug is currently under further investigation, and what we're going to look for is patients who have not become well during of their gluten-free diet. So this is high dose gluten. I mean, this is 3 gram, 10 grams, 8 grams, 5.6 grams. It's a lot of gluten for those who are not sensitive. What about the small dose of gluten? Can we explain this? Well, I have some personal experience. This is, again, I don't have celiac disease myself, but unfortunately my sister has contracted celiac disease. We share a summer house at the coast of Oslo. Sorry about that. Summer house at the coast of Norway. And this is a delicious sausage, which is typical Norwegian food. It's the sausage is gluten-free, but the wrapping is not gluten-free. So what did she do? She had a small piece of this wrapping together with the sausage and started vomiting, abdominal pain, brain fog. And so this is typically seen in many celiacs, but there's lack of good studies on such sensitive and super sensitive celiacs. Do they respond with IL-2? We do not know, but we're going to look into it. Are they immune activation? Well, we don't really know, but that is also a topic that we can look into. What about the overall literature in this field? In Europe, we allow in many countries wheat starch as part of a gluten-free diet. So the question, what about wheat starch? What about completely wheat-free, gluten-free diet? And what about accidental exposure? On the left here are several papers looking at symptoms and also mucosal immunology or mucosal status, villus atrophy, in patients who are on a strict gluten-free diet versus wheat starch gluten-free diet. And I can tell you that the papers on the left here, they more or less show that wheat starch is perfectly fine. On the right are some opposing papers, one from Professor Fasano looking at trace gluten contamination, and then a small study which is a citation classics. Many people have noticed this from Katassi and Fasano and co-workers, showing some effect of 50 milligram gluten per day. 50 milligram is not much. I mean, regular diet is how much? 15,000 milligram. So you can do some maths here. Ingestion of half a kilo, which is 1 pound of a gluten-free diet with 20 ppm, which is the recognized limit, gives 10 milligram gluten. Unlikely to show effect, or is it? Well, we are not entirely sure, but we have some data which show that maybe these small amounts of gluten do have a detrimental effect. This is the same study that we published in Gut some few years ago, 14 days with gluten, 5.7 grams per day. And we looked on those who responded with villus atrophy. And for this, we did laser capture microdissection. We can take out total tissue. We can take out epithelial cell layer and different parts of the biopsies that are fixed. And what we observe is that the responders have a lot of inflammation in their small intestines, whereas the non-responders, those who do not respond on a short gluten challenge, have much less inflammation in their intestines. So we ask ourselves, do we need really deep mucosal healing in celiac disease? And that question is still not answered. Then let's turn our focus on non-celiac gluten sensitivity. There are two major theories here. One is that non-celiac gluten sensitivity is an immune reaction to something specific, caused by a specific innate or adaptive immune reaction to proteins in gluten or any other things which is in the brain. The other is that, non-celiac gluten sensitivity may be a disorder resembling irritable bowel syndrome, a reaction to carbohydrates, and it turns out that bread is particularly rich in fructans or other carbohydrates. So these are mutual explanations to the phenomenon non-celiac gluten sensitivity. What we did was first, because we see a lot of these individuals that are live gluten-free, but they don't have celiac disease, and they want to, they ask ourselves, do I have a disease? What we did was that we gave them white bread, and you can see here the response. This is before they started eating bread. So on a scale, it is really, really low, so they are healthy. After they have been eating bread, symptoms go up. The scale here is from 13 to 91. So this is a very considerable response to bread. And we wanted to check out, is this the gluten content or is the fructan content? And so we did a randomized controlled triple arm study where we gave them fructan bars, FODMAP bars, gluten bars or placebo bars. And to cut a long story short, there was no sign of gluten effect here, but the fructans gave a response in these individuals. And furthermore, we had the chance to examine the cytokine release in these individuals, celiacs that are given gluten versus non-celiac individuals who are also given gluten. And again, this study here shows that in the non-celiac gluten sensitivity, there is just no cytokine response. And they don't respond to gluten, they respond to the FODMAPs in our studies. Can we turn this around a little bit? Well, this is a survey that we conducted some not long ago, internet survey, asking people with celiac disease, how do you do? What is your quality of life? And we find astonishingly many people with moderately reduced quality of life or really poor quality of life. And we wanted to ask ourselves, can we do something with this? These are patients on a gluten-free diet. We invited them to endoscopy. So we checked out their intestinal health. These are all patients who have had mucosal healing and still a lot of symptoms. And again, the short message here is that yes, we can interfere with FODMAP intake in these patients. It does help them to take away FODMAP, and we managed to take out a lot of FODMAPs in their diet. So yes, we can help these patients. Then finally, psychiatric disorders. In our guidelines, we were not very much focused on this, but there are a lot of associated psychiatric disorders. Anxiety disorders, autism, etc. Unfortunately, much of this is not really well studied. There has been histories about the gluten effect of gluten withdrawal in schizophrenia, not high quality studies. There is another signal that gluten intake in Down syndrome and the urine peptide levels shows association with lack of cognitive development. And finally, the story or the papers from Australia showing gluten-induced cognitive impairment, brain fog in celiac disease, and it does correlate with mucosal damage. So to conclude, gluten-containing food induces symptoms in celiac disease and non-celiac gluten sensitivity. There is a rapid adaptive T-cell immunological response. We think that trace amounts of gluten may activate response in sensitive patients. Some celiacs do not heal completely. Is that due to gluten exposure? We think it may be. Celiacs and non-celiac gluten sensitivity differ, and we are on the track of a drug that may help celiacs, and many others are working with drugs to help these patients. Finally, thank yous to my collaborators, the study nurses, the study staff, the endoscopy unit, and the research group, and in particular, my good friend Ludwig Solid, with whom I worked for so many years. So thank you very much.
Thank you very much, Dr. London. This has really been very exciting to hear about all your work. At this point, we would like to invite all of our speakers from this session so we could start our Q&A. And while everyone is turning their cameras on, I do want to thank the audience for fantastic questions, and the number of questions that have come through just kind of tell us how important it is for research to happen and for us to think about the neurological manifestations, even as gastroenterologists. So it's just, the interest is exciting. As Dr. Lebwohl and I have been conversing through text messages, it seems like we're trying to put the questions through in different buckets. So if I would just start off, it seems like there's a lot of questions about neuropsychological testing, blood work, and so on. So maybe I'll kick off the first question to Dr. Kupfer. And others in terms of the testing. So I know that after this symposium, everyone who's listening will be worried about getting TTG6, will be worried about getting the antigliadins. Where do we get that in the United States? Where are we with that? Do we have it? If not, what do we do with that? So Dr. Kupfer, if you could just kick that off.
Yeah, that's a really great question, Dr. Verma. And I think this conference is highlighting that we don't do a very good job of eliciting neurological symptoms in a systematic way. And I think that's something that we as a community could start thinking about. I think part of it is that this crosses over into a different specialty than most of the patients, are seeing mostly gastroenterologists or primary care docs, and we aren't always trained in these different tools. But I think it's a call to action for us to become more trained and to more objectively measure these kinds of symptoms. Regarding the question of TG6, we have not ordered it here, and I'd be interested to hear about other centers around the country, but also the world, about how, if it's even available to them, and how they're using it. I've certainly had patients ask me about it, and I've looked into it, but there are challenges to getting that testing, and then of course the interpretation of that testing and what that would mean. But I think this has been a fantastic session, and I am already going to make some changes in my clinical practice about asking about these in a more systematic way. Thanks.
So I know in the chat, Dr. Hoggard, you had said that that's something that you do on a routine basis. How about with Dr. London? Is that something that's done with your institution? And if I know in the United States we don't have it, how do we get to that? And how do we interpret, as Dr. Kupfer mentioned?
Was that a question? Yeah. So we don't analyze it in our, the whole hospital area, or we have a public healthcare system. We don't analyze in that, but there are some laboratories who may offer these kind of tests for a price, of course. It is not at all widespread.
So Dr. Hoggard, how can we get there? How can we move with the rest of your institutions?
I think we were fortunate to collaborate with the University of Cardiff, who've done a lot of the early work on TG6 testing, and that established a route into bring it into our routine practice from being a research tool. But I think the more people that ask for it, as soon as there's a market, there'll be a supply, and I think it's as simple as that. It's like the antigliadin antibodies, because they've gone out of fashion, and most people don't use them ever. It became very difficult for us to actually source those kits, and so we ended up switching manufacturer, persuaded them to do it for us, and then we had to recalibrate everything because we had a new kit, and so if people ask for it, there'll be a market and people will supply it, and it'll be fine, but we've got to ask for it in the first place.
And Ben, how about in New York? Is that something? I just wanted Ben's opinion, what they're doing in New York, and then Dr. Jabri, absolutely.
Not available as a clinical diagnostic in our lab. There's certainly interest. I'd probably be even more interested in the old native antigliadin antibodies, maybe, to come back. I don't yet have a good understanding of their kinetics, expected kinetics in this condition. I don't know if anyone does, but I think that it's a potentially valuable diagnostic. Bana, you were going to add?
I wanted really to congratulate you all, because I think it was a really fantastic session. So thank you for having accepted the invitation. I had a question concerning the link with dermatitis herpetiformis, where anti-TG6 antibodies have also been described. So do you see, I'm talking to Dr. Hoggard, do you see, and Dr. Cora, do you see more connections with neurological symptoms and dermatitis herpetiformis?
Well, I think there is some interesting biology there, isn't there? So if you look at I've said it in the chat a couple of times. So if you look at the age of people who present with celiac disease, who've got TG2 related disease in a sense, they tend to present in our institution. We have an average age in the 5th decade. And if you look at the people who present with the dermatitis petiformis, and also those people who have neurological presentations of gluten-related neurological disease, they tend to be in the people who are a decade older. And so there is that connection that you seem to need a longer exposure to the antigenic drive somehow in these individuals to end up with that presentation. And which I think is interesting. So I'm not surprised there's some crossover, but obviously, you know, as we know, dermatitis petiformis isn't driven by TG6, it's driven by TG3. So, you know, I suspect it's just a parallel pathway that these people are on that means you're going to find it with increased frequency in that population. You know, if you look at so when we did our studies, if you look at TG6 in the general neurology clinic, the levels are about 5%. But in the patients with gluten ataxia, the levels are 73%. You know, if you look at the levels of people with celiac disease, they're 32%. So, you know, there's a spectrum of positivity there, which kind of reflects the fact that TG6 is predominantly brain expressed.
So if I could ask a question, maybe addressing the elephant in the room, because there are these best-selling books, you know, Grain Brain, that imply that this is a huge problem, far outside, you know, how common celiac disease is. In other words, that gluten is potentially having neuropsychiatric effects on people. And many in the, I would say, mainstream medical or scientific community are very skeptical of that. I guess, point blank, how common is this problem? What percentage of the population do you think have some sort of neurologic response to gluten? I'll leave it there.
So there's an experiment we're currently running at Sheffield, which gets into that to a degree, because I think we can probably all, you know, in a nuanced kind of way, agree that gluten sensitivity can both be a much bigger problem than is currently clinically recognized, but can also have fed into, you know, an aspect of kind of fad diet as well. And I think that can make it difficult to actually tease out, like you're saying, you know, the prevalences of what's really going on within this. So we were looking a couple of years ago through the literature, and one of the elephants in the room, you know, there's this whole thing of certain gluten-related antibodies, like gliadin antibodies, native ones, as you say, Ben, being present in up to about 10% of the general healthy population. And it's a current just kind of assumption that this is benign, I suppose, and not related to anything relevant. So we're also not detailed in the talk that we did, but we're also currently running the first experiment that's actually just trying to kind of directly check that. We're recruiting people and want to investigate those who appear to be generally healthy, but who have gliadin antibody positivity against matched controls down the same sort of imaging and neuropsychological measurements that I've discussed so far, which will hopefully answer that question a little bit. You know, it will be interesting to see if it is possible to have, you know, some level of gluten immune reactivity by showing that and no consequences, or if in fact this has been a kind of a subclinical, up till now unrecognized problem that maybe is still affecting people, but we've just not been good at noticing it yet. So more on that space later.
Maybe just as a follow-up, maybe to Ken or to others who are engaged with patients, you know, is this something that you think is, you know, far more common than we appreciate? Or is it also possible that we are over-attributing some of these symptoms to gluten? I think for the individual, it's very hard to figure that out.
Yeah, I think a couple of points there, Ben, which is, I think it's not, I guess, over, you know, the opinion is not all that I think overstated. I think the issue here that we're dealing with is a couple of things. One is these symptoms are a bit difficult to pin down on what's going on in the first place. And then one other point that that I was very curious about, and I think is very important here, is the forgive me, I forgot who mentioned it, but the fad diet component. So I think it's just a really tough time to really, I guess, drill in on what the truth is right now. The best way to handle that is to do what we're doing right now, which is discussing it, and then also coming up with more of these more quantitative aspects of things, or imaging related work. So, and that's where I fit. And the last point I'll make too, and again, just, you know, my own personal experiences is you feel a bit different, but you can't put your finger really on it. And that's I've spent years doing that myself. So it's tough. It's a very tough problem.
Maybe just to add to that and what Dr. Kroll was saying, I think this is a call to the community that we need studies that use objective measures and control populations, because what's happening here, we need to compare it to the general population. And if we don't have those studies, I think there's very little necessarily that we can say about this. And that, you know, I think this is great because the group in Sheffield and others have really started in this path to really have, you know, controlled trials. So just a plug for that.
If I may just push this point, I think one thing that Dr. Hogarth and Kroll mentioned, and I would like them maybe to emphasize this more, and also link it to what Dr. Lundin said. It's only in real celiac patients that you have cytokine release when they eat gluten, and you don't see that in the context of gluten sensitivity. So when you start thinking about mechanisms, and when you start comparing symptoms, but also MRI images and so on, can you see differences in individuals who say they are gluten sensitive versus the real celiacs in terms of MRI images, in terms of symptoms? And what is your take on underlying mechanism based also on what Dr. Lundin has described?
Just take a step back from that. If you look at the work we published some time ago, only half of our patients have enteropathy with neurological disease. So there's a large chunk of people out there who do not have what one would call celiac disease.
Just for this point, I think the community now accepts very well that you have potential celiac disease with anti-TG2 antibodies. So the separation I'm making is patients with anti-TG2 antibodies who have cytokine release upon gluten challenge, who have a T-cell response, versus those who don't, not with enteropathy.
I'm not sure I can answer that, really. I don't think, certainly from our population, I don't think we know. So I think that's an unmet area of interest, to be honest. Yeah, I don't think we can answer that query, to be honest. Ian, have you any thoughts?
No, so I suppose there's a lot of that. It gets to a certain point, there's kind of semantics, and particularly the way the phrase non-celiac gluten sensitivity is often used can be a bit of a double-edged sword. I've certainly found throughout the literature. So, you know, on the one side, the patients that Nigel's describing that we get a lot have non-celiac gluten sensitivity. You know, that is that they have been diagnosed with gluten-related issues which are neurological in nature, but they do not have celiac disease when you look for TG2 or when you look for the enteropathy or any of those features. Then at the same time, a lot of people use the term NCGS to mean what could be, you know, fad dieting, you know, kind of type. There's an overlap then which opens up. So asking the question, you know, what changes can you see? I think first of all would depend on which of those populations you're discussing. I mean, certainly in the patients that we get at Sheffield, there is very, very obvious changes that you'll see on brain imaging in these people who are very responsive to a gluten-free diet, neurologically as well, you know, such as in some of the data that I've presented. And then in the other group, it's less clear. And we did do a pilot study a couple of years ago It was only in 5 people, so I'm always hesitant to kind of put too much weight on this. But we did a bit of blood flow imaging alongside a gluten challenge to see if that induced anything. And there was one subject of the 5 that seemed to have a very pronounced increase in cerebral blood flow, but tiny data set. I can't think of any other imaging work that's been done in that population of non-celiac gluten sensitivity.
Yeah, I think we've got to approach that area of people who've got no proof of immunological reactivity very carefully.
Yes, yeah, these were not people who had come through clinics who'd had a diagnosis of any kind. Yeah.
So if you would, from a practical standpoint, how would you decide that someone who's starting off with a panic attack or with some neurological symptoms, and then they get diagnosed with celiac disease, when does that become a neurological manifestation of celiac or gluten-related disorder? What's the time interval? How long does someone give and say, okay, well, let's see if this is just your baseline that's going to improve on a gluten-free diet? When do you think about doing scans or looking at TG6? What is the utility of all that in someone who starts off with some of these symptoms as baseline?
That's not precisely straightforward to answer. Certainly, there's no point looking in terms of weeks or months. So a lot of our follow-up imaging will be done. First time people will be followed up will be at a year for imaging. And that is also dependent on success with following the diet. The diet's not easy. You know, I had to go on a gluten-free diet myself not that long ago, and it's not easy. And you kind of make more mistakes when you start, and you gradually get, I've certainly found I've got better at sticking to it and not making silly mistakes. So you've got to make sure that people are truly, and we are pretty strict about what we define as gluten-free diet before we would say categorically that these symptoms aren't, you know, things that could be potentially attributed to the gluten sensitivity. You've got to be careful, haven't you, that you really are following a gluten-free diet. And that's one of the main reasons why we've ended up in the situation where we continue to use the anti-gliadin antibodies, which found pretty reliable. I mean, I know it's controversial. I mean, there are many people who would argue with us in different centres and say that, why do you bother? But we found it reliable and useful in our patients.
And do you find that the symptoms are different with different age groups? Is the intensity different, or the kind of symptoms are different? This is a question for everyone. Dr. Kupfer, do you find a difference in when you're seeing those young adults versus older people in terms of the intensity of their symptoms, or is it just what their baseline has been because they've started with a baseline anxiety or headaches or depression?
So hard to answer because it's so heterogeneous. You know, everybody is so unique and individualized in their symptomatology that, you know, sort of dissecting this out becomes challenging. And I think this is where the idea of, if it's related to exclusion of gluten in a securely diagnosed celiac patient, then I can attribute it to the celiac disease, but that can take months to years. I mean, I have a patient who has peripheral neuropathy, and we've been waiting now for years to see if it will resolve, and maybe there's a little bit, but sort of that's the challenge. And I think the area of psychiatric disorders is, you know, we're not even sort of touching that. That is a huge issue, and psychiatric disorders are incredibly common in the population. And so what's related to gluten and what's not becomes incredibly challenging. So I stick with my patients and I say, let's see if this gets better. And if it's not getting better, then I am quick to refer them to the appropriate consultant, because I also don't want to miss something else that might be going on that they're not getting treatment for, and actually maybe exacerbating the problem because they keep thinking it's related to cross-contamination, it's related to cross-contamination, and that's why my symptoms are continuing, and that can worsen underlying, especially psychiatric disorders. So it's so heterogeneous, which is why, again, we need better objective measures of even these symptoms. That's to me one of the challenges here.
Dr. Crowell, any words of wisdom for us if you look at it from a practical, very practical standpoint? There's someone out there who's been diagnosed with celiac disease or gluten, let's go with celiac disease. They've been diagnosed with celiac disease. They do have these underlying symptoms that are more neurological. What advice or what hope does one have in terms of, yes, we start a gluten-free diet. Is there a timeline? Is there something that someone can look at and say, okay, yes, we are reaching the end? You know, sometimes we look at biopsies and we look at our other endomysial and TTG2 and so on for celiac digestive disorders. But what hope, what should we be doing there?
I mean, it's a very important question. I should immediately have the flashing caveat sign in the background. I am not a medical doctor when I give the answer to this question. No, I mean, I think it's, for me, this is a really interesting area of research because it is a really rare situation of there being a condition which affects the brain and which can affect the brain in really quite severe ways, but which actually has a treatment. Because, you know, I've sort of been around in a few areas of neurological research, and often outlook is not that good. But something, I know it's a very difficult thing to follow, but, you know, the evidence is there that diet is a really significant treatment in this. And, you know, as Nigel's saying, we tend to need it to be stricter in the patients that we get compared to, you know, for the gastroenterological side of it. But certainly, you know, we're starting to show this evidence that it does help progression of, you know, physiological brain injury. You know, this sort of differing rate of atrophy, I think was a really promising treatment effect there in people who achieve immunological negativity. And then in terms of things like anxiety and, you know, these kind of psychiatric questions, there can be a bit of a dissociation between how, you know, somebody thinks and how far their brain has gone with these things. We can often see that on a physical level, sometimes brain injury cannot recover. We don't really grow brain tissue back, but at the same time, our mind is very flexible at dealing with things that has happened to it and can develop new coping strategies. So from a psychiatric and psychological point of view, I think the evidence is good that lots of people actually make a very significant recovery very soon after going on the diet, and that can hopefully be long-term, provided that the diet continues to be followed. I don't know if any of the real doctors would like to add anything to that.
I wouldn't use the term real doctors. I think we're all very highly engaged stakeholders, shall we say. But I have a question to the clinicians, the ones who are seeing patients and making decisions now in the face of uncertainty, because this happens a fair amount. Adult patient gets referred to you by a neurologist because of ataxia, difficulty balance, et cetera, maybe has some neuroimaging, and the MRI isn't quite as you know, clear-cut as what Nigel is showing us, but some non-specific abnormalities. So not normal, but not a slam dunk cerebellar gluten-related anomaly. They have a glide and peptide elevation, highly elevated, but negative TTG, no GI symptoms. And that's why the neurologist sent them to you, the celiac expert. So you tell them, keep eating gluten and let's do a duodenal biopsy. You do it, it's normal. They don't have celiac disease. They have a compatible HLA. And so they want to do something to help their ataxia. So they start a gluten-free diet. 6 months later, no better, but no worse either. But they're about to go on a cruise and they're sick and tired of the gluten-free diet. What do we tell them to do today?
Dr. Kupfer is an adult,
Nope,
so
don't make me unmute you.
I will stay away on pediatrics.
This happens, you know, and because
Yeah.
I think there really is uncertainty.
Absolutely.
Yeah, Ben, you always have the easiest questions for last. I think we have to acknowledge uncertainty. we don't always do a good job of that in medicine. We have to say this is an area we don't know. I think it may be the severity of their symptoms. So if they have had, again, I'm not a real neurologist kind of territory, but in working with a neurologist, I would say, based on how severe their symptoms were, and if there has been some stabilization on the diet, I suppose then perhaps it's safer to stay on the diet. But admittedly, I wouldn't, I don't know is the answer I would give, and we would just need to be, closely monitoring this individual. But, again, it would have to be in consultation with my neurology colleagues.
Any final answers before I know that we do have a hard stop now, but if anyone wants to.
I could give you the position that our neurologist takes, Professor Hadji Vasiliou. He's hardline.
The Gluten antibody sort of buys you, the Gluten antibody plus neurological symptoms buys you gluten.
If you've got the right HLA type, if you've got the antibodies, if you've got the right symptoms, and you've stabilized on a diet, all those things as a constellation, I know what you'd be saying. You'd be saying you need to stay on the diet.
Thank you very much. That's why we are not the neurologists. We are the gastroenterologists, and we really, really appreciate your wisdom. And we hope that we will be able to learn more and be able to bring it to our patients with science and also data. So obviously we need the patient population, but we also need, as gastroenterologists, to keep an open mind and learn from everyone. And at this point, I think we are being booted out, and I'm going to hand over the mic to Rachel. But thank you so much. This has been wonderful. Thank you, thank you, thank you.